Hi, my name is Ericka Bagi, Senior Medical Science Liaison for MDX Health, here to talk to you about a couple of our options for diagnostic and prognostic biomarkers for prostate cancer. First up, we're going to discuss Confirm MDX, which is going to be the only tissue biomarker that's able to address biopsy sampling error and really identify men that may be at risk for harboring clinically significant disease after a cancer-negative biopsy, meaning men that have benign, high-grade PIN, and ASAP atypia tissue on their prostate biopsy. Confirm MDX is going to be identifying the methylation status of three key tumor suppressor genes. GST-Pi is going to be found and methylated in up to 90% of prostate cancers, and has also been described as one of the most common human somatic genome alteration for prostate cancer. In addition to GST-Pi, we're going to be looking at the methylation status of APC, which is associated with apoptosis, and RASF1, which is associated with the cell cycle regulation. As these tumor suppressor genes become methylated, they're unable to perform those key tumor suppressor duties. On the right side of the screen, you'll note if we do assess DNA methylation, we're going to take into account those clinical risk factors to give a patient an individualized likelihood of having clinically significant disease on that routine biopsy or on that repeat biopsy. And for patients that are going to be DNA methylation negative, those are patients that can avoid a biopsy at this time and go back into routine monitoring. The way that we're going to identify the DNA methylation is via the field effect. As a tumor is present and wants to grow, it's going to start changing the cells and their tumor suppressor capabilities around it. And that's what we're going to be able to detect via that distance or the field effect through those cancer negative biopsies. Most recently, Confirm MDX had an abstract presented at one of the AUA sectional meetings. We were very excited to see new data about Confirm MDX and its relationship with MRI. Confirm MDX does a wonderful job and works very, very nicely with MRI. If we look over to the right side of the screen, as you can see, for Confirm MDX positive patients, almost 60% of those patients we were calling positive, lining up very nicely with that PIRED 3 to 5 patients. In addition to that, we actually identified a couple of patients that were deemed PIRED 1 or 2 that would have been missed upon MRI that actually did have clinically significant disease. And if you look at the bottom right corner, as you can see, a negative Confirm MDX plus a negative MRI can really add to the confidence in this patient not having clinically significant disease. We firmly believe that Confirm MDX and MRI really work well together and are not in competition in any way, shape, or form. The conclusion of the abstract was that it really may help to add in Confirm MDX in addition to that MRI and will really reduce those unnecessary prostate biopsies. Looking at the reports, the Confirm MDX negative report will report out as DNA methylation negative. This is going to come with a 96% negative predictive value for your clinically significant disease and a 90% negative predictive value for all prostate cancer. These are the patients that we can put back into routine monitoring, and we do not have to be running into a repeat biopsy at this time. As opposed to patients that are going to be DNA methylation positive, those are patients that we really want to prioritize in that diagnostic process. On the positive report, you're going to get a likelihood of any prostate cancer upon repeat biopsy. Then we're going to break that out to see which is going to be your percentage for your Gleason 6 disease, as well as what's that patient's likelihood for having clinically significant or Gleason score 7 and above disease. Directly below that, you're going to see the chart to the left, which is going to identify what cores and what genes were methylated, and then also a DNA methylation diagram for providers if they would like to go in and take additional cores in and around the area of methylation. Again, a patient that is DNA methylation positive really warrants that further investigation, whether that be an MRI in their near future or a repeat biopsy. Now we're going to discuss the genomic prostate score, formerly known as Oncotype DX. The genomic prostate score is looking at 12 key prostate cancer specific genes across 4 different biological pathways. The test was designed to address not only heterogeneity, but the multifocality of prostate cancer, especially in low risk or low grade disease for patients who are trying to make active surveillance decisions. One important thing to understand about the GPS score is the GPS score in itself is solely based upon tumor genomics and tumor biology. The GPS score, or the number value that you'll get on the report, is not associated with any clinical risk factors and pathological features, and it in itself has been shown to be an independent predictor of adverse outcomes. In addition to the GPS score, when we do start calculating the adverse pathology risk, distant metastases, and prostate cancer-related death, then we are going to take into account those clinical risk factors for that risk assessment. Most recently, we were really excited to see Dr. Brooks, who studied under Dr. Klein, who helped us originally validate the assay, to revisit and look at those patients and see how we're doing at 20 years. So we are going to be the only test in the space that has 20-year outcomes on our patients. First question we wanted to address was, is adverse pathology still an important endpoint at 20 years? And adverse pathology in our definition, which is going to be that T3A disease, so your primary pattern 4, or your non-organ confined disease will be our definition, which is a little different than how some of the competitors define adverse pathology. But again, looking at those patients and how they did, as we can see, patients that had adverse pathology had a marked increased risk for the distant metastases compared to patients that did not have adverse pathology, as well as prostate cancer mortality. We see patients that did have adverse pathology had a much higher risk of prostate cancer mortality at that 20-year mark compared to patients that did not have adverse pathology. So again, adverse pathology, as we define it with the GPS score, is still going to be a very important outcome when it comes to 20-year data. In addition to adverse pathology still being an important endpoint, Dr. Brooks also assessed, is the GPS score still a great predictor at that 20-year mark? And as you can see, it was a fantastic predictor. Patients with a GPS score below 20 still remained extremely low risk for distant metastases at 20 years. And again, same with our prostate cancer mortality. Patients with a GPS score 0 to 20 are going to remain very low risk for prostate cancer specific mortality at that 20-year mark, showing that the GPS score itself, again, tumor biology only, is still going to be an excellent predictor for these long-term outcomes of patients. If we look over to the right of the screen, kind of looking at the area under the curve, red line is going to be just Gleason score or grade grouping. Blue line is going to be the GPS score in addition to that information. As we can see, there's a nice marked increase of area under the curve with the addition of the GPS assay for both distant metastases and prostate cancer specific mortality. So not only is it an important predictor at that 20-year outcome, but it's also going to be improving the information that we currently have. Dr. Vip Patel, which I think a lot of people are going to recognize his name, also did a study for us in 2021, and he was really assessing how the GPS score does with adverse pathology and those patients that are going under radical prostatectomy. He conceptualized that the GPS score could be a great indicator or guide in making treatment decisions when it comes to surgical margins and lymph node sparings. When he looked at almost 800 patients, he did find that with a GPS threshold of 29, so 30 and greater or 29 and below, there was a significant higher risk for extracapsular extension or the extraprostatic extension. So within their own practice, they actually adopted the GPS score 29 to be a little bit more careful with that dissection on the tumor side. So not only can GPS aid in treatment decisions, but also when we're taking patients on for radical prostatectomy, how aggressive do we want to be with our surgical approach? Dr. Patel concluded again that it's going to be a very excellent test to help aid those decisions when we're designing those surgical strategies and taking patients to OR. Again, how wide do we want to go on our margins? Do we want to do lymph node sparing for patients, or do we want to take those nodes? So again, not only making treatment decisions, but also how do we want to form those treatments and how aggressive do we want to be? In regards to the GPS report, this is going to be the first page of the report. The top portion is going to be clinical information and demographics. The next portion is going to be that GPS score. Again, we've discussed that that's going to be a nice independent predictor. So this is going to be based upon that tumor biology only. We found in our study, 0 to 20 is a pretty safe patient to monitor. 20 to 40 is going to be an intermediate patient and really need to assess their status at that time. And 40 and above are going to be patients that are really operating like a higher risk patient. Below that, you're going to get that percentage risk for adverse pathology at radical prostatectomy. Again, we define adverse pathology as any primary pattern 4 or any non-organ confined disease. And then when we flip the report over, we're going to get a breakout of that adverse pathology, meaning is it more likely to be high-grade disease, or is this more likely disease that has exited the capsule or moved without or outside of the prostate gland? Below that, we are going to get those distant metastases risk at 10 years, as well as that prostate cancer death risk at that 10-year mark. Again, aiding in those treatment decisions. With that, thank you all so much for your time. I really appreciate it.